Well, good afternoon. I am Delaware State Representative Paul Baumbach, serving the 23rd House District, and it is Sunday, September 10th, 2023, just after noon, and it's time for our weekend update on Delaware Retiree health benefits. If you tuned in this, you know what's going on, but we'll go over that about 2 years ago and last year, actually maybe 3 years ago and 2 years ago, and then early last year, the Delaware state government selected the retiree health benefit that it provides to state retirees, and plan proposed that it would be changing from a Medicare supplement, like a Medigap, to a Medicare Advantage system. And there's quite a difference between the two. However, they portrayed it as substantially equivalent to what they had been doing with the Medicare supplement. This was announced to retirees in June, early June of 2022, and public meetings began in August, maybe late July, and there was a lot of concern over the change, taking away the underlying traditional Medicare, on top of which a Medigap sits to provide the last sort of 20% of coverage, taking that away and replacing it with a Medicare Advantage all-in-one, in the hands of a independent insurance company. So eventually came to pass that there was a lawsuit filed, and Superior Court Judge Justice Calvin Scott ruled that the state could not proceed with their proposed change, and said that the current system, which is known as MedicFill, had to be continued. So that was done in October, I think 24th. And what the legislature did, it had planned to do some stuff, but with the judge's order, it waited till January. We passed Senate Bill 29. Senate Bill 29 changed the makeup of the committee that had made the decision. That committee is called the State Employee Benefit Committee, the SEBC. And it also created a Retiree Health Benefits Advisory Subcommittee. That is chaired by Lieutenant Governor Bethany Hall Long and has two co-vice chairs. I'm one of them, and Senator Brian Townsend is the other. We've had somewhere around 15 meetings since early March to review retiree health benefits and to come up with recommendations. So that's what I give an update on. We had our last meeting on Friday afternoon, but I wanted to begin not with that subcommittee, advisory subcommittee, the RHBAS, is typically what I spend most of my time on, but I want to begin by talking about the State Employee Benefit Committee. Let's go to that one. There you go. So this came out Thursday morning. This is an announcement of a meeting in 8 days on September 18th of the SEBC. And can I make this larger? I'm sure I can. There you go. So Monday, the 18th, from 2 to 4, there'll be a meeting. This is a newly announced meeting. And there's two things that really struck my attention. Items 6 and 5. Let's start on the simpler one, number 6. As I said, the court ordered that the current MedicFill system be continued. The SEBC had voted to extend it. It had gone through December 31st of last year, and the SEBC had approved it going through June 30th of this year, and then through December 31st of this year, and then June 30th of next year. What they plan to consider and vote upon is whether to extend it through December 31st of next year. And that date's important because the SEBC, and you can see with number 5, is looking at a Medicare request for proposals. This is the process the state goes through to request that insurance companies provide bids to the state for providing the health care for retirees who are of Medicare age. So let me jump to here, which is what the SEBC presented at their meeting on August 21st. What you see here is that for grandfathered retirees, not that's terribly well defined. Well, actually, it is defined. Their view here of what a grandfathered retiree is someone who has retired by before January 1st of 2025. And for those individuals, you can see the second line, state employees who retired prior to January 1st, 2025 and are Medicare eligible. And what they would get is the same thing that they've been having, MedicFill. Now, I know that this whole nightmare has been revolving around a lot of people saying it's substantially equivalent to MedicFill. And therefore, there's a lot of skepticism anytime someone uses the phrase about the same, functionally the same, functionally equivalent, substantially equivalent. And I know that that people aren't going to believe it until they're actually experiencing it. But as I see the words here, this is saying for those who are retired by the end of 2024, the RFP would include a Medicare supplement plan. So not an advantage plan, but a supplement plan that's essentially the same as the current MedicFill system. But they didn't stop there. They went on and said, but this would be a multi-year contract. So it would start on January 1st of 2025 and go on for 2, 3, or 4 years. And some people are going to retire after 2024 here. So what happens to them? Well, then the RFP is would request additional plans. And what is it looking for there? Well, we'll have a supplement plan and we'll also have an advantage plan. So for those who hadn't retired by the end of 2024, the SCBC would be asking for bids for both a supplement plan and also a Medicare Advantage plan. This is, this was done on, I'll get the date in a second. So that's what they said they wanted, I think as of the 21st of August. We had our meeting of the RHBAS on August 24th, just I think 3 or 4 days later. And if I go to the minutes of that meeting, these are the minutes from the August 24th meeting, and I highlighted the motions that had passed. We had 5 motions, 4 of which passed. The first said that, is a motion that I made, that the RFP would not consider or accept any Medicare Advantage proposal. So Medicare Advantage off the table. That was the first motion, and it passed with only 4 no votes with 15 members, so it was 11-4. So that says that the SCBC's plan, if they follow our recommendations, would have to change and not include Medicare Advantage. Had people cheering, and people continue to worry about that. There's a lot of people who've spoken up at our meetings. Actually, the phrase I keep using is that due to unanimous feedback that from the public at our meetings, there's zero support for Medicare Advantage. Well, so again, there was concern that we make this motion, but the SCBC would ignore it. Well, okay, then we go and look at their motion. That's not the right one. That's the RHBAS. Let's try it again. The come up here. The SCBC agenda, the newly issued one, said the RFP will call for 1 self-funded plan for medical supplements substantially equivalent to MedicFill, and that's it. So potentially on the 18th, the SCBC will vote on their draft request for proposal document to strike any mention of Medicare Advantage. This is a big step. This implies, I'll infer, a reader infers. I infer from this that, and this meeting announcement was authored by the co-chairs of the SCBC, which is Cabinet Secretary of Human Resources, Secretary DeMatteis, and the Director of the Office of Management and Budget, Director Cade. They also serve on the RHBAS, and what they've done is they've issued an agenda that, to me, implies that they plan to propose to follow the subcommittee's recommendation to take Medicare Advantage out. I feel pretty darn good about this, but I plan to attend the meeting on the 18th and see that the SCBC executes it the way that I'm understanding it's proposed here, and specifically that the SEBC would be following the recommendations that the committee made on the 24th, the subcommittee made on the 24th. The other motions that that passed, this says that RFP, that request for proposal, the document that says we are interested in having insurance companies bid this kind of plan and that kind of plan, and who's going to be deciding that kind of stuff and how long the plans would be valid, that we'd like that to be that draft request for proposal document. We'd like it to be shared with the public at least a week in advance. We'd like it to be voted upon by the full committee, the SEBC, and we'd like public comment in that meeting to come before the vote. So if, for instance, the RFP is shared a week in advance, and if some members of the public look through there and find some issues they're very concerned with, they can raise that before the committee votes on it and says thumbs up, thumbs down, or we need to make some changes. So that's our second recommendation that we adopted on August 24th, and that was a 12-3 vote in favor of it. The fourth motion, also made by me, the first three were made by me, is to extend the term of the contract that we're bidding, we're asking for bids for, from a, sorry, I should go back to what they had proposed. RHB, nope, sorry, wrong one. Let's go to the RFP presentation. Okay, so let me find where they mentioned it. The number of years. They said that they only wanted a 2-year that scope. Okay, so down here, the last bullet. Initial term would be for 2 years with one optional additional year. So the max it would go from 25 through 26, and it could go through 27, but that's it. This is the first time we knew that that was the term they're looking for. That's different from the past RFP, which was for 3 years plus 2 additional optional renewal periods. Here they said we just want it for 2 with a +1 possibility. So we heard that and we made a motion that instead it'd be for a 3-year term with 2 optional 1-year extensions. The reason we did this is an awful lot of work from the subcommittee and from the public has gone into digging into what happened last time and trying to make sure that it doesn't happen again this time. And we don't want to have to worry about it happening again just 24 months later. So we think the minimum that we should be able to enjoy the certainty of the next contract is 3 years. So we discussed this, and again, it was a 12-3 vote in favor of requesting a 3-year term with 2 optional 1-year extensions. And then the last motion came from retired State Representative Bill Oberle, and what it said is, let's define what we'd like to be the grandfathering. Grandfathering is just if we make a change, who's affected by the change and who's not. We had, as a subcommittee, considered 3 different models of grandfathering, and we've looked at how the different models affect the dollar savings down the road. The 3 models are those who, it does not affect those who retire by the end of 2024, so we'll call that A. Model B is those who have less than 10 years of service to the state by the end of 2024. So those who've been working 8.5 years so far, no more than 8.5 years. So we wouldn't make a change to those who have less than 10 years of service. And then the third, option C, is this only affects those who are hired after 2024. So for making this change, we are making sure that the change, if you do see, it only affects those who, as they're considering accepting the job for the state, they know what the rules are way down the road when they retire, 20, 30, 40 years from now. So what the motion from Bill Oberle made was we're going to define it as affecting only those who know before they even accept the job what the retirement benefits will be when they retire. So these changes would not affect anyone who's currently working for the state, even those who start working next year, for instance. And it passed 9-6. 1, 2, 3. Yep, 9-6. So that's what we passed on August 24th. and are concerned with, well, nice, it's advice, but what is the SCBC going to do with our advice? And what it seems like is, at a minimum, they've taken that first motion to take Medicare Advantage off the table for the upcoming RFP. So 1 out of 4, it seems like they're seriously going to be considering, and hopefully they'll be seriously considering more of them. So that's enough of our SCBC deep dive. Let's get back to the RHBAS. We met this Friday, and we went through all the motions. Okay, so we did a lot of talking. Let me go over the presentation that we looked at as it relates. That's not the presentation that I want. That's the presentation I want. So this is the presentation that was distributed. A presentation like this has been shared at every RHBAS meeting. And in recent weeks, in recent meetings, it has included a summary of all the things, a summary table of all the things we've looked at. This all comes because we've got a $8+ billion shortfall between the cost of what we've promised current and future retirees and the money we've set aside to meet those promises. And that's a gigantic gap. And the whole reason why we're looking at this, the SCBC's looked at it in the past, and the RHBAS was formed to look at this, is to address that over time. 3 different ways to address it, or a combination. One is funding, putting more money into it. It's a gigantic hole, so it needs a lot of money, and because it's so big, it needs a lot of money over a lot of years. So it's really a multi-decade approach. And so funding is one piece, is putting more money in, and the second is taking less money out. So how do we take less money out? Well, one is we reduce who is eligible, or reduce how much the state pays for those who are eligible. So we can charge retirees half the cost if they want to cover a spouse, for instance. We can have it so that you need an additional 2.5 years of service before you get the state to pay 50% of the cost, and 2.5 years more before they pay 75% or 100%. Limited future vested retirees. These are people who may have put in 25 years, but they're only 46 at that time. We still almost 2 decades before they'll be eligible for Medicare. That's something where they've earned their pension, but they won't receive it because of their age. So we also wouldn't give them health benefits because they earned their years during a very early part of their career. And the other is to say health benefits, retiree health benefits don't kick in until a minimum age, say 60, 55, something like that. So that's the eligibility way to reduce the spending out of the system. Another way to reduce the spending out of the system is to change the plan design, change the level of benefit, the level of benefits you get. As an example, as I said before, generally, and I know I'm simplifying it, but Medicare covers about 80% of the cost for retirees' health costs. So if you're retired and you're 65 or older and you always paid into Medicare, then most of your bills, 80% of your bills, are covered by Medicare. Now, covered by Medicare because, number one, you paid into it every working day of your life, because a portion of your salary was set at 1.45%, was set aside by you, and the same amount was set aside by your employer to go into the Medicare Trust Fund. And in addition, every month of your retired life, once you're 65, you're paying an additional monthly premium. I think it's currently maybe $165 a month that goes to that trust fund. So those 3 levels of money has gone into the trust fund to pay for that roughly 80% of your costs of healthcare and retirement. So then you've got these supplements, these things that add on top of the traditional Medicare. And you may have a plan that pays 19 of the last 20%, or maybe the state could say, well, how about if we only do one that provides 13%, and you have to pay out of pocket, another 7%, the last 7% of those costs. So you can have a less comprehensive Medicare supplement plan. There's also other approaches. The MA is the abbreviation for a really nasty thing, and I'm being sarcastic here. It's Medicare Advantage. It's the system that takes that traditional Medicare of 80% plus a Medicare supplement for the difference, and it throws it out the door, and instead gives you this single thing that's called Medicare Advantage. You throw out your Medicare card, and with Medicare Advantage, you go to the insurance company, and they're the gatekeeper for what gets covered and whether you're eligible for it or not. There's prior authorizations and networks and things like that. That's one that costs. It has a lower cost than Medicare plus Medicare Supplement, and therefore it can save money for the employer, in this case, the state of Delaware. And then the third way that we looked at it was through a health reimbursement account, an HRA. And that's one where the state will provide a set dollar amount per year per retiree that they can then use to purchase, either to pay out-of-pocket costs or to purchase their own supplement plan off of what's known as the marketplace. Just buy it from a AARP or from an insurance agent, et cetera. And it's one where typically the dollar amount you get would be increased every year. I won't go into the details, but we looked at that. So we looked at 3 different ways to reduce expenses through benefit plan design. With 4 different ways we haven't finished looking at it for eligibility, and then we've looked at different ways of adding funding to it. So that's only the second slide of this presentation. Let's talk about a few more of the ones. He said, well, going back, we wouldn't just use one. This is one where we use some of a funding change, some of an eligibility change, perhaps, and some of a benefit change. So we looked at something like a total of 8 different combinations. I would say the main value of this, to my mind, is that it shows you that it's not additive. So if I go back a slide, if you change your baseline, right now we're putting 0.36% of payroll into the trust fund. And that has gotten us, plus other things we've done, has gotten us to around an 18% of filling the gap. Yeah, so we've got 18% of that total cost 30 years from now. We're on course to have that. If we were to then add one thing, which is adding 1% of the budget each year, and actually we did that. That was a recommendation that the subcommittee made to the legislature in April or in May, and in June, the legislature, through Senate Bill 175, took that step and put it into the code to require that. That's an additional 42%. And when you add that to the 18%, you get to about 60% level. So we got 60% by doing those 2. Well, what if we also do, say, the spousal share, and let's say we do, let's not do that one, but let's say we're going to charge, we're going to keep doing Medicaid, but we're going to charge retirees an extra 5% of the cost of the Medicaid, the Medicare supplement. So, okay, that will get you somewhere around 0.7 to 0.6% on top of the spousal shares, maybe, depends on which retiree model. Remember A, B, and C we talked about? We've got 3 columns, A, B, and C here. So we have one from this this set of rows, one from this set of rows, and we're at the 42/60% here. The thing is, it's not additive because it's just not. And the combinations show that to you. But as far as the details of the combinations, I don't think they're at all valuable because we don't know which of each of the rows, which bullets within each of the 3 categories we are comfortable with yet. And we don't know which column, which grandfathering we want yet. So the combinations were done, but I don't think I think you're going to be wasting your time if you look at them and get upset about anything. Regardless, what you will see in here is there is mention of Medicare Advantage. So one of our subcommittee members, Wayne Emsley, provided a motion on Friday to remove slides 11, 13, 15, and 16, I think. Ones that include mention, remove mention of HRAs. We've looked at this and said, and we had a member of the public say we didn't look at HRAs. We did. They must have missed those meetings. We looked at them, and what we found is, yes, we had saved money. We would do it if we only did a 2% increase to the dollar amount for the retirees. 2% doesn't come close to handling the rise in health costs. So this is something where it really hurts those retirees who live a long time, especially those who have higher health costs. It leaves them out of pocket paying a lot more than what they do currently. So yes, we save money, but we save money by hurting our future older retirees, especially with higher health costs. And if we do a 4% annual increase, which is, I would view, much more fair for people, we find it doesn't save money. It actually costs money. It makes the problem worse. So that's why we said no on HRAs. And Wayne said, if somebody said no to it, can we just take it out of the presentation and stop worrying people about something we've already said no to? Also, slide 13 talks about a Medicare Advantage plan. We've said as a subcommittee, we don't want that. Take it out of there. So taking it out there, and then 15 and 16 also have Medicare Advantage in there. So his motion was to take those out, and that passed. And I think it was probably 12-3, something like that. So that's what the subcommittee did. I'm trying to think if there's anything else actionable that they did, that we did, I'll say. That was the biggest stuff. There was a lot of talk about that. We haven't yet talked about, no, you know what? I have the presentation I didn't go to. So, all right, let's talk about non-grandfathered retirees. So these are people, if the SCBC and the legislature follows the recommendations of our subcommittee, grandfathering for any plan change is based on only those who are hired after 2024. Okay, so let's begin with that. Remember, who would this affect before we get too upset about things? And you notice there's 4 different categories here. So let's start at the top left. These are people who've been working at least 20 years, and therefore currently the state pays 95% of the premium cost, and they pay 5%. So this does 2 things. One is it increases the retiree share from 5 to 10%, again, for future employees who are not grandfathered. So you get hired, you know, okay, I worked so long, I'll have a health benefit, but I'm going to pay 10% of the premium cost. And then you're going to have a choice between Medigap G and Medigap L. G is close to Medicfill, but it's not as good. It has more out-of-pocket costs, roughly, I think, $500 more per year for most people. And actually, for the average person, I should say. L is think of L as being lower. It has a lower coverage, but it costs less. So it's one where you're going to be out of pocket a bit more for L than you would for G. So if you've got the state paying 95 or 90% of the coverage, you probably, we set it so that the premiums are the same. So if you've got 20 plus years of service, the premiums would be the same between the 2 plans. We know G covers more than L, so we hope, and we've designed it so that every retiree with 20 plus years of service, if this is adopted, would choose G, which is the better plan, which have less out-of-pocket costs. Both if you're the average person, this 50th percentile, if you're amongst the 10% who are most healthy with the lowest costs, or if you're part of the 10% who have the highest costs, still G is far better than L in all 3 cases. So why would we even offer L if we're almost forcing people to choose G? It's not for the people who have 20 plus years of service. It's those who have less. Let's go down here. Let's go over here. So currently, if you have 15 to 17 and a half years of service, you would have to pay half the cost, and the state would pay the other half the cost for that supplement, that Medigap, that health benefit that the state provides to you on top of the Medicare, traditional Medicare that you've paid for and the federal government provides. So if you're paying half the cost, it matters a lot what the cost is, and you may want L. So we look again at the 3 extremes. If you're the average person, you would find that you would save a little bit if you chose L, because you're saving more on the premiums. It's $400 less per year, or $250 less, $350 less per year in premiums, and your out-of-pocket cost is only $100 more. So you're saving about $200 a year if you chose L. If you're the more healthy side of things, it's even better for you to choose L. However, if you've got some chronic health issues, then your health costs are going to be higher as far as the full amount. Medicare covers about 80%, and there you'd be better off with G. Yes, your premiums are higher, but your out-of-pocket costs are much lower in G because it's more comprehensive than L. So that's why we want L, is to give future hires when they retire. We want to give them another choice so they can choose the combination, the version that works best for them in their health situation. And still, we're giving them a quality Medicare supplement negotiated by the state, and therefore probably lower cost and better coverage than what a Medigap G or L would be out there if you bought it from ARP or insurance agent. And the same kind of savings and choices are available if in other cases where you have less than 20 years. So if you pay all the costs and the state pays nothing here, so you've got less than 15 years of service, you can still buy into it. And here it's important. We think it's important to be able to offer L because it's going to be a lot less expensive if you're on the healthier end. But still, G is better if you if you expect and do have higher health costs. So I put this together to show the importance of having more than one choice. And it's most especially for those who have less than the quote full amount of years of service. And this is designed only for those who are not grandfathered. Those who are grandfathered, it's designed so that you're going to choose G. Now, let me mention G. There's MedicFill, which is custom. It's pretty much patterned after what's known as Medigap F. Medigap F is only available for those who are retired or Medicare age 65 and older as of a certain date. I'm going to say 3 years ago. I don't remember the specific date. F is not available to someone who just turned 65. So there you go for G. G is the same as F, except it has something like a $220 higher cost. I think it's a Part B deductible. It's unique to it, so it's a little bit more expensive. And I say it's more expensive because number one, it is, but also say it saves the state about $200 because the premium's less, and the state pays 90+% of the premium for the folks with all the years service. So G is a savings, but we'd only do that for non-grandfathered retirees. So even if we only offer G, that would still save the state some. But by having L in there also, we're giving really valuable choices to future retirees who have less than 20 years of service. So we presented that also, and I'm hoping that we can have more discussion at the next meeting on the 27th, and then be able to figure out. I'd like to finish this plan design recommendation for Medicare age, so that we can then look at eligibility changes that we're comfortable with, what kind of grandfathering goes with that, and with that, we may also decide on what cost share of the premium cost for the less than 65, the non-Medicare retirees. But I'd like to finish with the Medicare age retirees at the next meeting, so that we can start and come close, maybe even come close to completion on the sub 65 year retirees also. Okay, so that's not the one I want. I want the PowerPoint, which is that guy. So, okay. I don't know why we have the separate one already written. These just past things we went through. None of the stuff matters. I don't mean it doesn't matter. I mean it's not all that critical. Mentioned there's a slide in here that has a date. We met on the 8th. The 24th was last month. The 28th, that meeting has been changed to September 27th from 1:30 to 4 p.m. is the plan, and it's still going to be the same Delaware Department of Insurance office. Okay, I don't have any questions yet on here that I see. We've had, I want to thank especially those who showed up on the 24th. That was a very critical meeting. We had 4 very important motions and recommendations passed, and the presence of the public, I think, really mattered, along with the outreach that members of the public did before, during, and after that meeting. And at this point, an important question is how many of those recommendations will be embraced by the State Employee Benefit Committee, the SEBC, including at their meeting on the 18th. To me, an extremely important question is the issue of, is Medicare Advantage going to be excluded from the upcoming request for proposal process? But also we want to know about the term, and we want to know, is that request for proposal going to be shared with the public before it's finalized, will be voted upon by the full subcommittee rather than just done administratively. So those are some upcoming questions. It's going to be a few weeks before the RHBAS meets again, or at least, 2.5 weeks or so. I may do a very quick rundown, one of these guys' Facebook Live things, after the September 18th SEBC meeting to give you an update. It's a Monday meeting, so maybe Monday evening or something like that. I'll try to do that. And I always load this stuff up on YouTube so you can share it with anyone who does not follow Facebook. If there's no questions, fine on wrapping this up. I just want to say, I want to thank people for their patience. Again, we've had well over a dozen meetings, often 2 hours and sometimes 3 hours. And I'll answer that in a second. And there's been a lot of skepticism. Initially, when we passed Senate Bill 29, there was concern that the RHBAS was toothless and was just going to be a rubber stamp for the administration. I think that for those who stayed through the whole period thus far, they found that's not the case, that there's an awful lot of independence, a lot of digging in, rolling up sleeves, trying to find out everything you can before we make decisions and we cast votes. And I think what was may have been missed by some is that there were also changes to the State Employee Benefit Committee, the SEBC, that was put into place with Senate Bill 29. And that also changes the likelihood that the recommendations that we offered on August 24th will be embraced and adopted by the SEBC this month and next month and in the future. So, but I know that there is so much loss of faith in state government that retirees suffered during this, especially last year's decisions that sort of got sprung on them, sprung on you. So it's going to take an awful lot to build back that faith. I think that many retirees who have been plugged in are gaining quite a bit of faith in the advisory subcommittee. And we will see if we get that same positive development with the SEBC starting on Monday, the 18th at that meeting. Now, questions. And should we send another volley of emails regarding supporting your motion? I want to point out that these motions, these are collective efforts. The subcommittee, the only reason I would even put a motion forward is if I thought that the subcommittee would consider it. And subcommittee members have been wonderful. They've been so hardworking, all of them. So it's only because of their dedication that these motions were introduced by Bill Oberle and me on the 24th and by Wayne on this past Friday. So they're our motions, they're the subcommittee's motions. I think the whole concept should be if you're reaching out to members of the SEBC, I think the concept should be the legislature and the governor put the RHBAS in place to offer advice in this area. SEBC, you're responsible for the ultimate decisions. We would like you to very seriously consider every recommendation from the RHBAS. And personally, you may add, and we would like you to adopt them. So I think that should be the spirit of it. Obviously, it is their decision. They are set up in Delaware law to make these decisions, but we are set up in Delaware law to provide recommendations in this policy topic. So I think that's quite appropriate. And frankly, I think a lot of retirees are staying informed through a certain organization who has a 4-letter abbreviation, and that organization does a great job of providing information and guidance. Kimberly asked, explain what the elimination of vested. Oh my God. Yes. What is termination, vested, terminate? Oh my God. Yes. Who's defining who's grandfathered? I have 25 years in. How's that affect us with that amount of years? Appreciate your hard work on all the other committee members. Yeah. So Kimberly, thank you for raising this. I have, eliminate future vested retirees from eligibility for health care. Okay, there is actually a definition for that. To me, I think that's the most insane label that I've ever heard. So I think it's called term vested retirees, future term vested retirees. So eliminate, we know what that is. Future means there's some grandfathering going on. Vested retirees, that means someone who has retired and has earned a pension. Okay, so the pension has its own rules. I think it's 15 years in that you are, maybe it's 10 years in, that you are, I think it's 10 years in, that you're vested in the pension. Okay, now the pension, though, you have to wait until a certain age to be able to receive it, but you've still vested. You've earned the right, they can't take it from you. Okay, and there's even survivor rights to that. So if you have worked enough years to be vested in your pension, but it is one where you're not eligible for health care. So okay, let me think on this one. Oh, I'm sorry. No, that's not right. Okay. If you've worked enough years to be vested in your pension, but you're at a younger age such that you are not eligible to start receiving your pension. So that's the gap. It is your pension, but it doesn't start for a bit. If that describes you, then if we make this change subject to a grandfathering, you would be ineligible for health benefits at any point from the state. Okay, so let's say you get a bachelor's degree in teaching, age 21, you start working at 22, you work 30 years for the school district you're 52 at this point, and if that is, so you've got 30 years in and that pension is yours, but it's not going to start until, I don't remember the rules for the pension, let's say it's 60 or 62 or something. You've got another 8 years, 10 years before you'll get the pension. If we did this, and if you were not grandfathered, then you would not receive retiree health benefits. And instead, you might think about working a few more years so that you would coordinate your retirement date to be the date that your pension would begin. So you work as long as it takes to have the pension start. And that depends on years of service and your age. And again, I don't know the details of the pension. I've been so laser focused on this. But that's the thing is, you're vested in your pension. You can easily be vested in your pension before you're eligible for the pension to start when you retire. So if you retire before your pension can start, and if we have a grandfathering that doesn't cover you, then you would lose that eligibility. Keep in mind the RHBAS, the advisory subcommittee, said we shouldn't make changes for anyone who's not already employed. That's the most generous to the employee / retiree. The least generous would be you got to retire by 2024 to not be hit with these changes. I don't know which grandfathering we would use for these. I'm pointing to something you can't see. That doesn't help too much now, does it? So let's try that one. So these eligibility changes, including the future vested retirees, I don't know which of the grandfathering, I don't know if we're going to recommend that it be adopted. And I don't know if we do recommend it be adopted, which grandfathering column we would use. So Kimberly, I can't answer that yet. And that's where I know there's an effort there's desire by some subcommittee members to have us wrap our work up sooner rather than later. And my concern is we haven't yet wrapped our hands around your question, Kimberly, about if we do term vested, then who do we apply it to? Great question. We don't have an answer yet. So that I expect that we're going to be speaking at length at our September 27th meeting about that, and I'll report back at my Facebook Live after that. So not decided yet. It's unknown, and we will see. One thing I'll point out is that when you look at these four, there's the one that has the least dollar impact is the issue of eliminating future vested retirees from eligibility. So there's the thing of, is the juice worth the squeeze? I think there's some stupid phrases out there, but it says, let's say it takes an awful lot to, climb the orange tree and pull that orange down and then cut it up and put it through the squeezer and you finally get half a glass of orange juice. Is it worth it? Is the trouble worth it? Is it worth, pardon my expression, pissing off a number of employees who'd be affected by this if we're getting less than a 1% closure of that funding gap. Maybe not. Maybe you want to go for where there's more juice, and maybe that's at saying you don't get the health benefits until you have an extra 2.5 years, instead of it being at 15, 17 and a half, and 20 years. What if it's at 17 and a half, 20 and 22 and a half years, as an example? Don't know, not decided yet, under consideration. That's I put it there. Okay, Kristen, looks like both Kate and Dennis voted against each of the motions that were passing. Reasons why that was the case: these motions seem like reasonable ideas. Is a concern you directly in charge are against them. So Kristen's asking, and if I go to the minutes, that I think all 4 of the motions had 3 reliable no votes, and that was the 3 members of the governor's cabinet. The answer is yes, and this is not me reading into their minds. This is statements that they've made. I think that the finance department secretary Rick Eisenberger pointed out he doesn't like ruling things out until you rule things in. So as far as ruling out Medicare Advantage, he'd say, I don't want to rule that out until you tell us what plans you're going to that are going to save the state money. So, I mean, that's understandable. The governor has been very clear that he wants to make real progress on closing this funding gap. So motions that, for instance, the grandfathering one, the last motion from Bill Eberly, that said we're going to extend the grandfathering as the furthest we've ever considered, which is it only affects future hires. That's one that they feel was only looked at saving the state money a long time out, and therefore they felt that was not consistent with what they would like to see the subcommittee doing, which is taking steps to save the state money sooner. Do keep in mind that rightly, the government, state government, and look, I work for the state government, I'm in the legislature, so I can't dodge this bullet, but there's lots of complaints that we've been kicking the can down the road. And by having the grandfathering approach that the last motion had built into it, is one that kicks the can down the road more decades than the other 2. So I think those are 2 of the reasons that were given. Secretary DeMatteis points out that, for instance, the RFP related ones regarding put it in public comment can come. It's voted upon by the SEBC. The term should be 3 years, not 2 years, with some extensions. The phrase she used is that would be micromanaging the work of the SEBC, which is statutorily assigned, to the committee and overseen by her cabinet department. So, those are the reasons given. I'll leave that there. I hope that answers it well. Henry, I indeed, I think the subcommittee has done great work. I've never worked as hard on a subcommittee or task force as for this one, and I know that my fellow subcommittee members I think they all can say the same thing. This has been an amazing amount of work by so many people and by the public, by members of the 4-letter organization. So thank you all for that. Definitely more talking is necessary. Yes. Okay. I think those are all the questions. I think everyone knows my email. It's also in there in the thread. I think I got to all the questions. So that looks like it. I do want to point out that, I've mentioned that the state was taken to court and the judge ordered, you can't move ahead with Medicare Advantage. You got to keep Medicare going. That case is appealed at the state Supreme Court level, and that's moving forward. Some filings, I think, happened this past week. So we'll see, whether some judgments happen from there. We're working on what's currently the rule, and in my mind, the judge was very clear that the state cannot proceed on Medicare Advantage at this time. There's an outstanding court order to that effect. So I think that's pretty clear. Well, okay, thank you. And I'll get this up on YouTube. Usually I can do it within a half hour. Depends on how fast technology is. One thing I want to point out is that there's a power outage in Dover, and some of the servers are down, so you cannot find things like the past agendas and reports and stuff, or at least I couldn't at 11:30, 11:45 this morning. Just give it time. Power will come back, servers will be back, all that material will be back. I think the state does a great job, and I'm going to say the DHR, the Department of Human Resources, does a great job of keeping all these documents online, so you can look at them, you can find the minutes, you can put it into Word and highlight it if you want. So this is it's all there available for you. These are public meetings, and we're working really hard to make sure that this process be done in the light of day. And we think when we do that, people can understand it far better and won't be caught surprised the way that they were last year. Thank you for staying informed. And Debbie, I won't say winning and losing, but I think that the public is better served with the subcommittee, making sure everything is out in the open, giving the public a clear opportunity to speak up, and for the public to join us as we dig deep into things that were done without public involvement in the last iteration. So yes, I agree. This is, I think, far better done, and I think the subcommittee has done a great job. I want to thank the chair, Lieutenant Governor Bethany Hall Long, and my co-vice chair, Senator Townsend, along with all the other members. I mean, I know that Representative Ramon and Senator Pettyjohn are working really hard on this. The 3 cabinet secretaries, the 2 representatives from state employee unions, our 3 retirees, the insurance commissioner. I think I got everyone. And if I missed somebody, I'm very sorry. But there's 15. We've had 15, and everyone's working very, very hard. I appreciate everyone's work. With that, I hope you have a good rest of your day. Please take a moment to tomorrow to remember 9/11. I'll be at a ceremony Newark is holding at 8 a.m. tomorrow, and let's work together, and we can get much more done that way. Thank you so much.